Hi, I'm Dr. Altaf, and today I want to have a conversation that could genuinely save your life, or the life of someone you love. Colon cancer is one of those conditions that sits in a strange and frustrating place in medicine. On one hand, it's one of the most preventable cancers we know of. When it's caught early, the outcomes are genuinely excellent. On the other hand, when it's found late, it becomes one of the most difficult cancers to treat effectively. And here's the part that concerns me most as a doctor. Colon cancer doesn't always make itself known early. It can grow quietly for months or even years before producing any obvious symptoms, which means the people who survive it best are often the ones who paid attention to subtle, easy-to-dismiss changes in their body and then acted on them. That's exactly what today's video is about. I'm going to walk you through the early warning signs of colon cancer that are worth taking seriously, explain the biology behind why these symptoms happen, and then talk about what modern screening actually looks like. Because the screening options today are far better than most people realize. Let's start with some context because it matters. Colorectal cancer, which is the broader term that includes both colon cancer and rectal cancer, is the third most commonly diagnosed cancer in both men and women across the United States, United Kingdom, Canada, and Australia. But here's the trend that has genuinely alarmed the medical community over the past decade or so. Rates of colorectal cancer in younger adults are rising. Cases in people under 55 have roughly doubled over the last few decades. And according to data from the National Cancer Institute and several large cancer registries, colorectal cancer has become the leading cause of cancer death in men between the ages of 20 and 49, and it ranks near the top for women in that same age group. That is a significant shift from where we were even 20 years ago. Now let me put the survival numbers in context, because this is where early detection becomes everything. When colorectal cancer is found at a localized stage, meaning it's still contained within the colon and hasn't spread, the 5-year survival rate is approximately 91%. That's an encouraging number, but if the cancer has spread to distant organs by the time it's found, that survival rate drops to around 13%. The difference between those two outcomes is often just one thing: how early it was caught. So, understanding the signs and knowing when to act on them is genuinely important. Let's go through them carefully. Changes in your bowel habits. The first thing I want you to pay attention to is any meaningful, persistent change in your bowel habits. Now, everyone's bowel habits vary. And a couple of days of loose stools after a rich meal or a day of constipation while traveling isn't what I'm talking about. Those kinds of temporary changes are normal and common. What warrants attention is a change that persists for several weeks without a clear explanation. That might look like new onset constipation or frequent loose stools or an alternating pattern where you swing between the two. Here's the biology behind why this happens. The colon's primary job is to absorb water from digestive material and form stool. A tumor growing within the colon can disrupt this process in a couple of different ways. If the growth irritates the bowel lining, it can increase fluid secretion and accelerate the movement of material through the gut. That's what produces diarrhea. If the tumor creates a physical narrowing or partial blockage, it can slow the passage of stool and produce constipation. And in some cases, when a tumor partially obstructs the colon intermittently, you can get that alternating pattern, constipation followed by diarrhea, which is actually one of the more distinctive patterns worth discussing with your doctor. None of these symptoms by themselves confirm cancer. Irritable bowel syndrome, inflammatory bowel disease, and even dietary changes can all produce similar patterns. But a sustained, unexplained change lasting more than 3 to 4 weeks, especially in someone over 45 or with other risk factors, should prompt a conversation with your doctor rather than a wait-and-see approach. Blood in the stool. This is one of the most recognized warning signs of colorectal cancer, and it deserves careful explanation because people often misinterpret what they're seeing or reassure themselves too quickly. Blood in the stool, the medical term is hematochezia when it's bright red, can appear in several ways. You might notice red blood mixed into the stool itself, blood in the toilet bowl, or blood on the toilet paper after wiping. Here's what I want you to understand. The most common cause of this kind of visible rectal bleeding is not cancer. Hemorrhoids, swollen blood vessels around the rectum, are extremely common and are probably the most frequent explanation for blood on toilet paper or in the bowl. Anal fissures and a condition called diverticulosis, where small pouches develop in the colon wall and can occasionally bleed, are also common explanations. But here's the clinical reality. You cannot determine the source of rectal bleeding by looking at it. Hemorrhoids look exactly like early colorectal cancer bleeding, and while the odds favor a benign explanation in most cases, no no one should simply assume that's what's happening without getting it properly evaluated, particularly if the bleeding is persistent, recurrent, or accompanied by any other symptoms I'm describing in this video. If you notice blood in your stool or on the toilet paper on more than 1 or 2 occasions, please get that checked out. It's almost certainly nothing serious, but almost certainly isn't the same as definitely. Dark or black colored stools. This is distinct from the bright red blood we just discussed, and it points to a different location in the digestive tract. When stool appears black, tarry, and unusually foul-smelling, the medical term is melena, this usually indicates bleeding that originated higher up in the gastrointestinal system, such as in the stomach or the small intestine. As blood travels through the digestive tract, it gets chemically altered by digestive enzymes and acids, which changes its color from red to dark black. The most common causes of melena are peptic ulcers and gastritis. Colorectal cancer is less frequently the explanation for truly black tarry stools, although right-sided colon tumors can occasionally produce darker colored stools because the blood has further to travel before being passed. This is worth knowing, but it's not the most common presentation. The key message here is simple: black or tarry stools are not normal, and they should always be evaluated promptly. If you ever notice this, don't wait to see if it resolves on its own. Iron deficiency anemia. This one is subtle, and it's one of the signs that genuinely gets missed, sometimes for a long time. Some colorectal tumors bleed very slowly and in very small amounts, too little to be visible in the stool, but enough over weeks and months to gradually deplete the body's iron stores. Iron is essential for building hemoglobin, the protein in red blood cells that carries oxygen. When iron stores are depleted, hemoglobin production drops and anemia develops. The symptoms of iron deficiency anemia, fatigue, breathlessness on exertion, paleness, feeling cold, are common enough that they often get attributed to stress, poor diet, or simply getting older. And most of the time, in most people, that explanation is correct. In women with heavy menstrual periods, iron deficiency anemia is extremely common and usually dietary or hormonal in origin. But here's what changes the calculation. In an adult man with iron deficiency anemia and no obvious dietary explanation, or in a postmenopausal woman, or in anyone whose anemia is unexplained, colorectal cancer needs to be considered and ruled out. This is a point that guidelines in the UK, US, and Australia all emphasize. Unexplained iron deficiency anemia in adults over 50 should prompt a colonoscopy to exclude a colonic source of occult bleeding. If you've recently been told your iron is low and you haven't been given a clear reason why, ask your doctor whether a bowel investigation is warranted. A feeling of incomplete evacuation. This symptom is called tenesmus, the persistent sensation that you need to empty your bowel even when you've just done so, or the feeling that your bowel never fully empties. It's an uncomfortable symptom, and it's easy to dismiss or attribute to something like irritable bowel syndrome. And indeed, tenesmus is a common feature of IBS, particularly the constipation predominant type. It can also occur with hemorrhoids, inflammatory bowel disease, and pelvic floor dysfunction. But when tenesmus is new, persistent, and particularly if it's accompanied by other symptoms on this list, especially rectal bleeding, change in stool caliber, or unexplained weight loss, it becomes more concerning. A tumor in the lower colon or rectum can press on the bowel wall, creating the false sensation of stool being present. If you've been dealing with this feeling consistently for several weeks and it doesn't have an obvious explanation, it's worth bringing up with your doctor. Abdominal bloating and persistent gas. Bloating and gas are among the most common digestive complaints, and in the vast majority of cases, they have completely benign explanations. Diet, gut motility, the composition of your gut microbiome, stress, these are all far more common causes than cancer. But persistent, unexplained bloating that doesn't respond to dietary changes and lasts for more than several weeks can occasionally indicate a colonic problem worth investigating. When a tumor grows large enough to partially obstruct the colon, it can trap gas behind it, producing bloating and abdominal discomfort. A growing mass can also disrupt the normal fermentation processes in the gut, alter the balance of bacteria in the colon, and slow the transit of waste, all of which can contribute to excessive gas production. The distinguishing feature here is persistence. Bloating that comes and goes with certain foods is almost always dietary. Bloating that is constant, unexplained, and accompanied by any other symptom from this list that warrants attention. Unexplained weight loss. Unintentional weight loss, meaning losing a meaningful amount of weight without trying, without dietary changes, and without a clear explanation, is a symptom that always deserves medical investigation. It's not specific to colorectal cancer. It can be associated with several other cancers and medical conditions. But it's on this list because it does appear in colorectal cancer, particularly in more advanced stages. The mechanism involves several factors. A growing tumor can physically impair nutrient absorption in the intestine. Many cancers also drive weight loss through a process called cachexia, a complex metabolic syndrome in which the body's normal energy regulation is disrupted by inflammatory signals from the tumor, including cytokines like TNF-alpha and interleukin-6. These signals effectively reprogram the body's metabolism in ways that cause muscle and fat loss even when caloric intake seems adequate. If you've lost more than 5% of your body weight over 6 to 12 months without explanation, please get evaluated. Weight loss like this is rarely insignificant. The most important sign of all, no sign. I want to be direct with you about something that every oncologist and gastroenterologist knows well. The most common presentation of early colorectal cancer is no symptoms at all. That's not meant to alarm you. It's meant to explain why screening is so important. The polyps that eventually become colon cancer can grow slowly over years, and in most cases they don't cause any noticeable symptoms until they've become significantly larger or more advanced. The symptoms I've described above are real and worth knowing, but in many cases, colorectal cancer is either entirely asymptomatic in its early stages, or it produces symptoms so mild and non-specific that they're easy to explain away. Which brings me to screening, because this is where you can take real, meaningful control over your risk. Colorectal cancer screening, what you need to know. The current recommendation in the US, UK, Canada, and Australia is that adults at average risk should begin colorectal cancer screening at age 45. Some guidelines previously said 50, but the evidence supporting screening at 45 is now well established, and most major cancer organizations have updated accordingly. There are two main categories of screening: colonoscopy and stool-based tests, and both have genuine merit. Colonoscopy is considered the gold standard. A gastroenterologist passes a flexible camera through the entire length of the colon and can directly visualize any polyps or abnormal tissue. Crucially, if a polyp is found during a colonoscopy, it can usually be removed at the same time, so the procedure is simultaneously diagnostic and therapeutic. If your colonoscopy comes back completely clear, the standard recommendation is to repeat it every 10 years. The main limitations of colonoscopy are practical. It requires bowel preparation the day before, which many people find unpleasant. It typically involves sedation, and it carries a very small but real risk of complications, including bleeding or perforation. These risks are genuinely rare, but they're worth knowing about when discussing options with your doctor. Stool-based tests are a meaningful alternative for people who prefer a non-invasive option. These include the fecal immunochemical test, commonly known as the FIT test, which looks for blood in the stool that isn't visible to the eye. There are also stool DNA tests, such as the Cologuard test in the United States, which look for both blood and abnormal DNA fragments that can be shed by polyps or cancer cells. Stool tests are done at home, require no preparation or sedation, and carry no procedural risk. The trade-off is that they're less sensitive than colonoscopy for detecting precancerous polyps, and they need to be repeated more frequently, typically annually for the FIT test and every 1 to 3 years for stool DNA tests, depending on the specific test and your risk profile. The most important thing is not which test you choose, it's that you choose one and actually do it. And there are situations where earlier screening is appropriate. If you have inflammatory bowel disease, Crohn's disease, or ulcerative colitis, screening should begin earlier and be more frequent. If you have a first-degree relative who was diagnosed with colorectal cancer, the recommendation is typically to begin screening at age 40 or 10 years before the age at which your relative was diagnosed, whichever comes first. So if your parent was diagnosed at 42, you'd want to start screening around age 32. Your doctor can help you work out the right timeline based on your specific family history and risk factors. If you have any of the symptoms I've described today, particularly if they're persistent, unexplained, or occurring alongside each other, please don't wait for a scheduled screening appointment. Go and speak with your doctor sooner. Most of the time, there will be a benign explanation. But the time to investigate is before a problem becomes serious, not after. What you can do, starting today. Let me leave you with a clear, practical picture of where to focus your attention. Know your family history. If a parent, sibling, or child has had colorectal cancer or significant colorectal polyps, make sure your doctor knows and that your screening plan reflects that. Don't dismiss persistent symptoms. Bowel habit changes, rectal bleeding, iron deficiency anemia, unexplained weight loss, and persistent tenesmus are all worth discussing with your doctor, especially if they've been going on for more than 3 to 4 weeks. Start screening at 45 if you haven't already. Colonoscopy is the most comprehensive option, but a stool-based test is far better than no screening at all. And one more thing worth saying, lifestyle genuinely matters here. A diet high in red and processed meat, low physical activity, obesity, heavy alcohol use, and smoking are all associated in the research literature with meaningfully elevated colorectal cancer risk. The evidence on these risk factors is some of the most consistent in cancer epidemiology. I'll be covering colorectal cancer prevention in detail in an upcoming video, so if that topic interests you, make sure you're subscribed so you don't miss it. If today's video gave you something useful, a clearer picture of what to watch for, or the nudge to finally book that overdue screening, then it did exactly what it was meant to do. I make these videos because I believe that well-informed people make better health decisions, not out of fear, but out of genuine understanding. That's what this channel is about. If that's the kind of medical content that matters to you, I'd genuinely love for you to subscribe to Dr. Altaf's channel. There's a lot more coming, and I think you'll find it worth your time. Take good care of yourself, and I'll see you in the next one.